The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining our webinar on Senate Bill 795, a tool to provide advocacy options for survivors seeking medical forensic care. This is Michelle Rowland-Schwartz. I'm the Executive Director here at the Oregon Attorney General Sexual Assault Task Force, and appreciate all of you logging in today to listen to our webinar to talk a little bit more about this bill. Before we begin and introduce our guest trainers here today, I do want to go over a couple of bits of information with you. I can't get it to slide. So before we begin, the materials you've received were created by the Sexual Assault Task Force specifically for the purposes of this training, and we ask that you not reproduce the material without consulting with us first, for the primary reason that statistics, information, and best practices may change on a regular basis, and we want to make sure that information is updated each and every time the information is shared. And additionally, the session is not intended to provide any legal advice and shouldn't be relied on upon as such. So for today on our webinar on Senate Bill 795, we're just going to do a review of the law, what has changed, what stayed the same, the varied advocacy response that we know exists across the state, refer folks back to SART protocols and making a plan in your community in response to the bill. Really pleased to have a number of folks with us today instructing with us, and I'm going to have them go around and introduce themselves, a little their name and their position and where they work. We'll start with Kim.
Hi, I'm Kim Larson. I'm the Director of Victim Assistance with the Marion County DA's Office.
I'm Nicole Broder. I'm a Sexual Assault Nurse Examiner and the SANE Program Coordinator for the Oregon Sexual Assault Task Force.
I'm Bibi Beltran. I'm the Executive Director of Sexual Assault Support Services in Eugene, and we serve all of Lane County.
And this is Lisa Norton, the Executive Director of My Sister's Place out of Lincoln County.
Excellent. Thank you all for being here. And again, for those just joining us, this is the webinar on Senate Bill 795, and I'm Michelle Rowland-Schwartz, the Executive Director here at the Oregon Sexual Assault Task Force. If you're not familiar with the task force, we were formed in 1999 by then Attorney General Hardy Myers at the request of statewide advocates and activists who wanted to put some energy and work behind addressing and improving our response to and prevention of adult and adolescent sexual assault in Oregon. Our mission is the effective prevention of and response to sexual violence through collaborative, comprehensive, survivor-centered strategies. We have over 100 Oregonians, multidisciplinary Oregonians who serve on our Task Force Advisory Council, and they serve on one of 8 subcommittees listed here. It's our offender management, criminal justice, campus, medical forensic, legislative and public policy, victim response, prevention education, and men's engagement. And much of the work of our membership informs our 3 programs here at the task force, including our SANE Certification Commission, which Nicole Broder, our SANE coordinator, provides administrative support in addressing and helping sexual assault nurse examiners become certified across the state. Our other program is our prevention program. Megan Foster is our prevention coordinator, and she helps us lead and facilitate primary prevention education across the state. And last but not least is our Sexual Assault Training Institute, which provides training for multidisciplinary responders across the state of Oregon. I'm sorry, we're just managing a couple of technical issues before we dive into the rest of the webinar. Sorry, guys. If folks could, if you can hear me, please comment on the sidebar and let us know if you can see the screen. Currently, we have the slide up with the 8 subcommittees, or if you only see a Let's Get Started screen in front of you. Okay, they can see them. They can see them. They can see and hear. Excellent. Great. Thank you so much. We appreciate that. Sorry for the technical issues. I'm glad we got that out of the way at the beginning of the webinar and not while we're into all of the good stuff. So if you're not familiar with the Sexual Assault Task Force and you would like to join us for one of our task force meetings, our next task force meeting, statewide meeting, is in Salem on February 1st. And you can RSVP to Judy Hayes, our membership coordinator here, and we would love to see you and join all of these fabulous people you see here in front of you, many of you who are on the webinar with us today. So before we dive into the webinar, we would like to know from all of you, what are your specific concerns about this bill? And if you would be willing to answer in the sidebar so that we can make sure that we address some of your concerns and questions throughout the webinar today. And if you can just take a moment and do that in the sidebar. Victim-centered approaches. How broadly is advocate defined? These are some great questions. I'm seeing folks wanting to know about how advocates are defined, what are victim-centered responses. What are the requirements of advocates when sharing information with victims? Okay, these are great. Thank you so much for your feedback, and please keep them coming. We'll keep checking in throughout the webinar. So Senate Bill 795, how did we get here? We wanted to give you a little bit of an overview of the passage of the bill and the needs for Senate Bill 795. So Senate Bill 795 actually builds on ORS 147.425, which is Oregon's personal representative law. And that law gave victims the right to a personal representative when they were at the hospital seeking medical forensic care, but it did not mandate the providers inform victims of their right. And so the passage of Senate Bill 795 would not only require that medical personnel and law enforcement inform victims of their right, but it requires that they call an advocate when survivors present for care. One of the other important things that we wanted to address, and that's really important to us in looking at policy and legislative work out of the task force and with our partners, is essentially making sure that victims have the opportunity to make decisions for themselves, and want to look at ways that we can build autonomy for each and every survivor in the state, and believe that Senate Bill 795 is in the spirit of building that autonomy. And what we know from hearing from advocates and other medical providers across the state is that a number of things were happening in the hospital setting when victims presented for medical forensic care. Either a healthcare provider or law enforcement may have informed them that they could call an advocate. We know at 2 o'clock in the morning, when presented with that information, that many survivors don't want to bother another person at that hour, already feel overwhelmed, don't want to burden anyone, and so often declined advocacy services when not necessarily presented with all of the information about what advocacy could do for them. The other challenge that we heard from providers across the state was that there may have been or were challenges in terms of the protocol and when advocacy would show up, that there may be tension between providers, and we wanted to make sure that that discretion of providers calling an advocate out was removed so that advocacy could come out, present information to survivors, and allow survivors to make decisions on their own. So our experience is that when we rely on others to explain what advocates do, it is often inaccurate, and as a result, victims are unable to make an informed decision. And the best explanation of what advocates do and what their role is comes from advocates. It's our belief that Senate Bill 795 will reduce barriers to advocacy services by offering survivors the opportunity to discuss their options with an advocate in person so they can make an informed decision about their care. And survivors can't consent unless they are aware of the full range of options available to them. So we were able to pass the bill unanimously in the House and Senate. It was a bipartisan bill and had great support from so many statewide providers. I see folks on the webinar, many of you who have a lot of expertise in this area, who have great medical advocacy response in your community, and I know that many of you participated in crafting this bill and helping us advocate to make sure that advocates can be there and share the information about their services. And so folks from the Coalition, the Oregon Law Center, DOJ, to the Sheriff's Association, the Hospital Association, and many more that really helped us pass this bill. And we're so grateful to Senator Monis Anderson and Representative Leininger for their advocacy and taking this bill to the floor for a unanimous vote. So I'm going to turn it over to Kim, who's going to talk a little bit about Senate Bill 795 and what has changed and what hasn't changed in the law.
Okay, I think when I look at Senate Bill 795, one of the things that comes to mind for me is that I think this is an example of a bill that really kind of came after what current practice really is for a lot of folks. And so it kind of memorializes what a lot of folks already are doing and what we know is best practice. But for a lot of people, these are things that already are happening in a lot of our communities. And so it just kind of memorializes in the law what we would like to see as best practice. So to kind of break it down a little bit into what might be new information versus information that really isn't new to what we're doing, you can see on the highlighted part, the first part there has some of the new pieces, the things that have changed in the law. And it talks about the fact that as soon as a sexual assault victim has decided that they want to participate in a medical assessment, it's at that point that either the medical provider or law enforcement officer needs to make sure that a victim advocate is there. They need to make reasonable efforts to make sure that an advocate is there. The information that's there talking about SART protocols isn't new. That's information and practices that we already are doing in our communities. And so really the piece is about, do we have an advocate on scene at the time that a victim is there? And so just to highlight it a little bit better, the part that's highlighted in red is really the significant change in the law that didn't exist before. And it requires that, one, they shall. And so there's really not a choice around, are they going to use discretion to bring someone out or not bring someone out? It's pretty clear that the medical provider shall call an advocate out, and they have to make a reasonable effort to make sure that an advocate's there and present and available for a victim to talk to. And the reason this is so important, Michelle touched a little bit on this already, is the fact that advocates are going to be the best situated to be able to describe what we do. We all can talk about what other people's roles are. We can talk about the SANE's role, we can talk about law enforcement's role, we can talk about a prosecutor's role, but the best people to explain their roles are the people doing the work. And so in order for victims to truly have access to services and make that informed choice that Michelle talked about, was to have a good explanation of what the responsibilities are and what our services are. And so that's really what's behind this piece of the bill and the change. So what stayed the same? Most of it. Most of it are things that we already are currently doing in our counties within our current practices. And I think, again, a lot of us will find that when looking at this bill that it really doesn't change significantly what we do in most of our communities. So the part that's highlighted on this slide really shows things that we're already doing as advocates. And And so it may not have been mandated by law, but there are things in our practices as advocates that are really inherent to what we do as advocates. So to kind of give a better description here, we've put what Senate Bill 795 requires and kind of put it next to what we do in current practice. You can see the first part is that once an advocate's called out, they have to clearly tell a victim that they get to choose. They get to choose about whether they want our services, and that includes they get to decline our services. Again, this is something we already do as advocates. That's part of recognizing the victim's autonomy and the ability to make choices about their services. That's also why it's so critical that advocates are the one explaining what the role is and what we can do, so the victims can actually make an informed choice. But again, this is something that we're already doing as advocates. It is very much a part of what we do as advocates to respect that autonomy of the victims we're serving. So the second part is that that advocate who's called out can't impede the medical assessment or the provision of medical services. Again, our personal representative bill or law already reflects a similar requirement. As advocates, we're trained. We know what we're supposed to do when we're responding out to serve a victim. We know not to interfere with the questioning. We know not to collect evidence. All of those things as advocates, we know what to do and what not to do. We know what our boundaries are. We know how to stay within those boundaries. And again, this is already a requirement that really is reflected in the personal representative law. And so it may be worded slightly different, but the meaning behind it is the same. And so it's very, very much a part of what we do as advocates already, and respecting the choices of the victims and making sure that we're not interfering with the process that needs to happen if a victim has chosen to go through a medical assessment, and really contributes to that informed consent that we want victims to be able to have. Another type of autonomy that this bill supports, and really isn't a change, is the fact that it focuses on what your community, individually as a community, has decided they want your response to be. And so it doesn't dictate that you have to do your response a particular way. It just says you need to look at your county protocols, and you need to follow what your county protocols are. And so it respects that autonomy of the community to know that every community is different, and to know that you get to decide what your response looks like, who's doing the response, how that looks in your community. It also, I think, supports the requirement that you have a SART in your community that's functioning and has a protocol. And so if you don't have a protocol established in your community, this is another good reason to get that conversation going, and to make sure that everyone's on the same page, so that everyone knows these are the folks that do the response, this is what that response looks like, and that's how it feels for our community. But again, that is not a change. That is something that we already recognize in our communities and participate in our communities with.
So I think one of the things that we always need to acknowledge is that there can be a variety of programs that may respond, especially in like your rural communities. For example, if you look up on the screen right now, we've got 3 and plus another responses. And we acknowledge that for each community, it's going to look a little different. And the importance of this is to recognize that community autonomy piece. Many of us have already done the work in establishing protocols. What I really enjoy about this particular bill is it's an opportunity for a conversation is what it is. And from a rural perspective, this also is an opportunity to plan a little bit more. Many of you know, if you come from a rural community, the relationship is everything. It's in key to establishing those somewhat the ones that look seamless responses. We all know that things happen in the meantime. Things happen. It might be somebody's not available, those kind of things. But when you look at that community autonomy piece, you've got to remember that, we all have a role to play, and that's unique for each one of us. We just have to remember that Senate Bill 795, is not prescriptive. It basically, like Kim says, it's doing the same thing. It's putting into law what we've already been doing in practice. So for me, SB 795 is really an opportunity to relook at your protocols and see, are we meeting the needs? Are we planning for the inevitable? Because I think that's the most difficult thing, at least from a rural perspective, is sometimes you may have one response person, maybe they're already on another call. So this is just for me the opportunity to just bring those conversations up in your SARTs, or to get those conversations starting from a point of, hey folks, we need to be talking about this because this is coming down the pike. I know locally that's kind of the conversation we're having right now, is what does that look like in practice? And from a rural perspective, we do have responses from all of these agencies. So we plan for that. We have backups upon backups, and we have really great working relationships with each of these programs to ensure that no victim is ever without an advocate at their disposal.
And this is Bibi Beltran from SAS, and just to talk a little bit about what the spirit is of SB 795, and really it is exactly what you see on your screen, which is that it's survivor-centered, it promotes autonomy, and it's all about consent. So what we know is that when survivors have as much information as possible, then they're the ones who actually get to make an informed decision about what's best for their situation. This is something that as advocates we've been doing since advocacy started as a field, and just like as Kim said, it just memorializes the practices and makes sure that, again, the discretion isn't up to a medical provider or law enforcement to initiate the advocacy response. So advocacy response is so crucial in the immediate aftermath of a sexual assault that really we need to be there. And as Michelle and Kim and Lisa have said, advocates explain our services best. So we know that, and lots of folks who helped with this bill recognized that and promoted that and had our backs. And so really this is what we're saying, is that medical advocacy and any other system that survivors engage with are really complicated. So they're really complicated, and they can be very overwhelming. So although we may not necessarily have prolonged contact with that survivor in the aftermath of the sexual violence episode, we at least have made that initial point of contact so that they know who that they can reach out to if they have a billing issue, or if they, had evidence collection that was anonymous and now they want to explore how to go about making a reported crime. So as long as we're there, I feel like survivors have many more options than if we weren't. And again, it's up to us as advocates to ensure that we explain that, and get together with your SART folks and make sure that you know who's responding. In Eugene and Lane County area, it's SAS, but that's not always going to be the case. I know in Marion County, it's a DA's office. So as long as everybody who does response to sexual violence is on the same page, survivors are going to be better served. All right, so capacity. This is something that we definitely heard a little bit about as far as what happens now. And so I guess my response to that is do what you've always been doing. So yes, there will be times when you have reached capacity. We have experienced that at SAS. We have 2 layers of coverage after hours, and sometimes that advocate is called out multiple times. So make sure that you have redundancies in place. At the very, very least, ensure that you have written materials at the medical facility or wherever this exam is going to be taking place. So that way, at least if you're not there in person, there are materials there that the survivor can reference and refer to, and as much as possible, make them accessible and inclusive, so that way you don't have to have a PhD to understand what is written in those materials, and it makes it easy as possible for survivors to access those services should they need.
So this is Nicole Broder, and just kind of recapping what the importance of what we're talking about here. We know that these medical forensic exams are a critical access point for victims of sexual assault in order to access comprehensive healthcare services. We know that these exams and the access to them and resources helps reduce long-term negative health consequences that are experienced by survivors of sexual assault. And we know that advocacy provides complementary care during this medical forensic process, and that having a coordinated community response really just ends up with better outcomes for everyone. Medical forensic response is a really critical service for survivors of sexual violence. So here's my challenge to you all, and it kind of echoes what's already been said by some of the other folks on this webinar, is get to know your SART. The more that you know these protocols in advance, the more connections that you have to other people involved in these protocols, the better for everyone. So get to know your local emergency department if that's where the exams are taking place. Get to know their algorithms, their training, know what kind of knowledge they have on their end, and make sure that they know how you fit into this process, because for you two to work together, there needs to be a lot of understanding on both sides. And also make sure that your emergency department knows that it's part of your local protocols, especially depending on what kind of sane response there is already in your area. Sometimes local EDs are kind of catching up to this. So you can really help be a touch point and bring them into kind of the current era and into current best practice. We know that sometimes rural areas struggle with this in particular because it can be really hard to maintain a sane response and therefore to maintain sane and advocacy relations. So we have been doing some work with the Oregon Hospital Association in order to improve access to medical forensic care across the state. So that's something that we're kind of already looking at. And then I've got some homework for you as well, which is to look up some statutes. It's good to know the laws that support your practice. So we have a list of ones that we recommend getting really familiar with. And just to give you a little overview, these statutes look at the SART mandate itself, that mandates a SART in every county. These are the statutes that talk about the right to a personal representative, the statutes that talk about requirement to have SANEs or to contract with SANEs, and the statutes about advocate privilege. But really dig into these, get to know the language, get to know the details, because this is what's supporting your practice and what will support community coordination as well. Okay, and so just to kind of talk about where we're going with some of our advocacy training next year, I'm really excited to announce that the Sexual Assault Task Force was recently awarded our 4th Pride Foundation Community Grant Award. And with this award, our focus is really to increase access to advocacy services for transgender and two-spirit survivors who are seeking medical forensic care. It complements some of our previous trainings through the Pride Foundation grants, which we offered to SANEs around the state to improve medical forensic care for transgender sexual assault patients. So now with this emphasis on helping them gain access to advocacy, we really hope that these trainings will play off of each other in a really good way and help increase access across the state. So the exact opportunities and dates will be announced in 2018, but it's an area that we're really excited to be working in here. And I also want to highlight that we've set up a lot of mock exam opportunities around the state. In general, in the past, these mock exams have been geared for SANEs, and they still are, to help SANEs in training and experienced SANEs practice the medical forensic exam in a really supportive environment with our instructors. We bring them up now because we've had a push lately to include advocates, because we find that a lot of advocates don't necessarily have the chance to sit in on a lot of medical forensic exams, and so would like more comfort level with those exams, would like to practice interfacing with a SANE. We find that it really benefits the advocates practice, but also the SANEs practice, helping our SANEs and our SANEs in training learn about the resources available to advocacy and how to best work together during the exam to really create a really supportive environment for the patients as they're going through them. Last year in particular, we had advocates attend attend our exams in Ontario and in Roseburg. Quite a few advocates, actually. It was really exciting. Got great feedback from both advocacy and from SANES on what it was like to work together in this practice environment and really run through scenarios and get to know both roles better. So if you're an advocate listening to this webinar, I encourage you to check out our SANE mock exam training opportunities on our website, and please feel free to sign up for those and attend. We would love to have you there.
Great, Nicole, thank you. One of the questions that came up, and I'm going to ask him to help us address, was around confidentiality and the roles of different advocacy programs and the limits of their confidentiality. And I'm wondering if you can just talk about that briefly.
Sure. So nothing in this bill changes anything around your roles and responsibilities with regard to confidentiality. And so that's going to maintain, you're going to maintain whatever you're currently doing. Now, if you're a system-based advocate, your abilities with regard to confidentiality look different than if you are a community-based program. If you're a community-based program, you have the added layer of protection of privilege. And so as long as you've met all your requirements and are able to offer that. But when we're talking about really when we're interacting one-on-one with victims and survivors, the level of confidentiality we offer, I mean, we all follow the same basic rule, right? We can't disclose that personally identifying information without the informed consent of the victim, written consent. So we're all operating with that same basic rule. The difference with a system-based advocate, though, is as a DA-based program, I am operating under the umbrella of a DA's office. I'm part of a law enforcement agency technically. And so there are some rules that come into play that apply to our prosecutors that by extension apply to me as well and limit my ability to keep certain kinds of information confidential. But when I'm interacting with victims one-on-one, I'm not going to just be sharing information with others about what we're doing, and we're going to protect their confidentiality as much as we can. If, as a community-based advocate, you have a broader ability to protect that confidentiality, and you actually have a broader mandate to be able to do that. And with your privilege, that keeps you from being able to have someone, or for someone else being able to come in and demand that you provide information. System-based advocates do not have that protection. And so that's probably the biggest difference between the confidentiality and privilege piece when you have a system-based advocate or a nonprofit. And so working with your partners to know how that looks. It's really important when you're at your SARTs that everybody knows what your limits are and what your role is, and so that you don't have those tensions between law enforcement or anybody else because they feel like you're not sharing information. Those conversations should be happening at your SART, but when it comes to the response, being able to protect that information, is that basic rule applies to all of us. Just understanding and knowing where you're based affects your abilities around that can be important.
Great, Kim,
Yeah.
Thank you so much. And then, Nicole, can you address a question about age of consent for medical care and I think a reference to MDT SART?
Absolutely. So when it comes to the application of this law to our patients who are seeking care after a sexual assault, any patient 15 or above can consent or decline their own medical exam. And so when they're in discussions about what kind of care they want after the sexual assault, the advocate should always be called. Under that, I really recommend going back to your MDT protocols and your SART protocols to see exactly how that's handled in your community, as it may differ. But definitely for all patients 15 and above seeking medical care after a sexual assault, we always want an advocate to be called out for them.
And then, Vivi, I'm wondering if you can answer a question about providing advocacy services, even if the survivor is not interested in forensic care, they're only wanting to access medical care, and what you do in your community or any recommendations you have.
Sure. We just, really at SAS, we meet survivors where they're at. And so it's not uncommon for them to actually not want to have forensic evidence collected at the time. So we explain to them all their options. So we validate their options and acknowledge that, they know what's best for them. So many times survivors just want to make sure that they're physically okay, that they want to be checked out to make sure that everything is fine and there are no injuries. They also are more concerned with STIs and, potential pregnancy risks. So they have access to all of those without doing the forensic evidence collection. So we just make sure that they know that. Yeah, we just want to make sure that, like I said, that's the reason that advocates are there, so that they can explain all of these different avenues for survivors who may be, really overwhelmed with all of these options and, systems really in the acute aftermath of a sexual assault.
And then Nicole, we had one other question about training for emergency department staff.
Yeah, and this is where I do really recommend getting in touch with your local emergency department. We try to do trainings for our SANEs and have our SANEs also reach out to the departments in which they work to really get this education out there about the importance of calling advocates and about calling them in a timely manner and all of that. But really what's going to give you the best chance of making sure that you are called each and every time is to really build those strong relationships with your emergency department, or if there's another site where exams are done, making sure that you have strong connections there. I've heard of some places where advocates will come at shift change and talk briefly to the nurses, or come to a staff meeting, or maybe have brochures out or some sort of flyer up in the nurse break room or at the nurses station. All of these are good options, and it's really going to depend so much by community which option is going to be the most effective, and make sure that new staff are also trained in these protocols. So build those relationships and see how that education can best go forward to make sure that there aren't any gaps, and to make sure that this is followed each and every time.
Nicole, can I jump in? This is Lisa. One of the things that we have actually done is incorporated our local hospitals onto our SART, not just our SANE nurses, which they're amazing, but we actually bring in our hospital administration, and that really seems to help. And I know that may not be an option for everybody, but it's great to have nursing supervisors. It's great to have, we even have our dispatch people at our SARTs, because we know that the information needs to be consistent throughout. And so especially if you've got interested parties at the administrative level, it's pretty important to keep them involved as well. So I think that's another avenue. But, and I really go out of my way. I mean, every one of the administrators, every one of our SANEs have my personal cell phone number, because I don't ever want somebody to not have advocacy, even if there's some difficulty along the way. So oftentimes I'll get a phone call like, is this? Yep, call me out. So I think it's the importance, like you said, Nicole, of those relationships, and really individual communities developing those kind of bigger talking points in terms of, how we can do our jobs even better.
That's such a great point. And the higher up you get with that kind of food chain in the hospital, the better too. Because we know that a lot of these exams do come in through the ER, but then sometimes you get them coming up on the floor or in other areas. And so if you don't have trained people there, or trained umbrella people to help talk them through what may be a new process for them, then that could be a problem. So that's a great point.
Great. And then we have one more question about the training that advocates should have, and the 40-hour training for community-based programs, the training that VAP advocates go through, and whether or not volunteers are able to provide medical advocacy, and if that's something that you all incorporate in your programs. Phoebe, if you wouldn't mind.
Sure. Yes. It would be wonderful if we had a whole wealth of volunteers who are able to respond after hours. We haven't necessarily seen that to be true, but our community is different. We have a lot of volunteers who happen to be students who are great and wonderful, but they also leave the community. So our agency, although we have volunteers, as far as like those who stick around long term in the community, those are a little bit harder to come by. But absolutely, as long as an advocate has the appropriate training, I would encourage them to shadow as much as possible. And sometimes that may not happen in your community. And I know that at SAS we probably see more sexual assaults than in other communities. So I'm always welcome to have other advocates and volunteers from agencies do a little bit of shadowing. Of course, we can't guarantee when crisis happens because that's the nature of advocacy. I definitely want folks to get that experience and feel comfortable, because really as advocates, our role is to be grounded. And, you can't necessarily be grounded if you're feeling really unsure about what you're doing. And also, I find that there's power in saying, I don't know, but I'll find out. So yes, volunteers, absolutely. We would welcome more. Yeah.
And I know our DA-based VAP program actually does have a couple of volunteers. I'm with BB. I mean, it's really hard to ask a volunteer to get out of bed in the middle of the night. That's usually not the level of volunteering that you find. It does happen, but I think sexual assault response is such a specific thing that it can be challenging to find those volunteers, but I would definitely recommend it. I try, when I'm training volunteers or even staff, I try to have them shadow each one of the people that responds to sexual assaults, because I feel like you find your own vibe in watching how other people perform. And so while I may be good at what I do, I know that other people in my office are also good, and I want them to shadow under that. And even as far as the DA's office, I would like for my my volunteers and or staff to shadow under their staff as well. I think it's really important that everybody knows what everybody's doing, and there's that level of trust that comes from the relationship building of even just spending time together over a cup of coffee.
Mm-hmm. This is Cam. Yeah, I agree with what everyone has said. We, like Vivi talked about earlier, our coverage in our office is kind of 2 layers. We've always got 2 people on call all the time, but that first layer for us is provided exclusively by volunteers. And so we have a fairly large pool of volunteers that are willing and able to get out of bed in the middle of the night to go do those calls. But we provide really extensive training too. I mean, we want people to have the tools that they need to do the work. And so I think that's a pretty critical component when you're using volunteers, is making sure that they're well trained in order to be able to do the work that they do.
Can I also add to that? One of the things that we have done is taken DA-based volunteers and actually given them access to our 40-hour online training in the effort, because, it's really hard to get sexual assault specific training any time of the year. So even by giving them that access as good partners, our community-based advocacy programs can be offering that up as a way to help the training and support volunteers in other programs as well. I think it's important that whenever we have resources available, that we're sharing those kind of resources, because whether it's the DA's victim response or the community-based response, I know that each one of the advocates that responds are actually well-trained, and I have complete faith and trust in them. And part of that is being able to share our resources when possible.
And this is Michelle, and I will say that my experience in doing medical advocacy is the 24-hour coverage, that we would not have been able to provide the services that we did without our volunteer program. And we had volunteers responding after hours, and they were expected to go through the 40-hour training and understand our SART protocol. And when, if we had multiple calls out, when we would call in the DA victim-based program or the tribal advocacy program, or if it was military sexual assault, the advocate from the Air Force Base. And so it was really important for our volunteers to know all of those layers, that they could call a staff member on call if they, if they had questions or concerns, and that they would have a staff person back them up, but to understand the SART protocol as well. And then also that you have someone in your organization, if you utilize volunteers, that support them, because this is, very intense work, and depending on your community, the kind of the age range in which you're going to see. And so I would recommend, if you're thinking about starting a volunteer program, to really talk with some other programs in the state that do that, and what works for them, what doesn't work for them in terms of supporting their volunteers and their paid staff as well. And so highly encourage that. I'm going to just check for any more questions here before we log off. So if folks have questions, go ahead and put them up in the sidebar. Give you a minute to do that. All right, not seeing any. I want to just say thank you to all of you for participating in the webinar, for everything that you do in your communities. Again, we know that we have so many people on this call who help contribute to the language, to the bill. You added your testimony, you added your logos to the floor letters in the Senate and the House, and we just are so appreciative of your advocacy and your support of this work. Really, truly believe that this is such a critical service for survivors of sexual violence in Oregon, and we want to be as supportive as possible. So if you have any questions, provided you our contact information here, you're welcome to reach out to us, and if we don't know the answer, we'll find somebody who does. So again, Lisa, Bibi, Kim, Nicole, thank you for being here today and for all of you joining our webinar.